Sairam and Namaste. I'm Aniket Rali from Vanderbilt University in Nashville, Tennessee, in the United States. And over the next few minutes, I look forward to discussing with you post-cardiac surgery shock management. I greatly appreciate this opportunity to spend some time with you all and discuss this very important topic. Over the next few slides, we will be covering several aspects of management of shock in those patients that have just undergone cardiac surgery. We will be focusing on the goals of resuscitation. We will define what euvolemia is and how we may achieve it. We may discuss the different vasoaplasia therapies that are available to us. And then we will conclude our conversation with treatment algorithms that are available for those patients that remain vasoplegic despite multiple vasopressor medications. The first most important concept to cover is that of the goal of resuscitation. So what is it that we are trying to achieve in these patients that are in shocked state after their cardiac surgery? And some of the measurable parameters that we aim to achieve in these patients is that of a cardiac index greater than 2 liters per minute per meter squared. In those patients that have a Swan-Ganz catheter in place, you may obtain a saturation out of the distal PA port and hope for that saturation and titrate medications to a saturation that is greater than 60%. In those patients that do not have a Swan-Ganz catheter in place, you can also get a mixed venous saturation, a central venous saturation that is out of any central line. And that saturation, as long as it is greater than 50%, is a reasonable number to target. Ultimately, you also want to make sure that the mean arterial pressure in these patients is greater than 70 millimeters of mercury. What is it that we are trying to achieve by maintaining an adequate cardiac index and an adequate mean arterial pressure is that the end organ is being adequately perfused. There are several markers of end organ hypoperfusion, and there are several markers that tell us that the end organs are being perfused adequately. One such marker is that of a urine output greater than 50 cc's per hour. In a patient that is making this much urine, it's a good surrogate marker that the kidneys are being perfused adequately. Similarly, in patients that have lactic acidosis, when you see that there is a resolution and a downtrending of this lactic acidosis, that tells you that normal end organ perfusion is being restored. The first thing we want to achieve in order for us to restore normal perfusion is to ensure that the patient has adequate volume that is available for the heart to pump forward. At the end of the day, the heart is a pump, and if a pump is empty and does not have enough volume, it will not be able to pump anything forward. One marker that we use to assess for euvolemic status is that of a central venous pressure of at least 8 to 10 millimeters of mercury. In those patients that do not have a CVP of 8 to 10 millimeters of mercury, the treatment generally involves giving them a 250 to 500 milliliters bolus every 30 minutes until you achieve this CVP. How can we confirm that the patient is no longer fluid responsive? In other words, once we have given somebody this 250 or 500 cc bolus of fluids, how can we ensure that giving them more fluids is not going to be beneficial? There are a few different ways we can check for that. In those patients that are on mechanical ventilation and are intubated, we can check for respiratory variation in systolic pressure in these patients. And if that respiratory variation in systolic pressure with breathing is less than 15 millimeters of mercury, in other words, if there is less than 15 millimeters of mercury difference in what their systolic blood pressure is with inspiration and what it is with expiration, then you can say that this person has been adequately fluid resuscitated. Similarly, if this difference is less than 15%, then you can also note that this person is adequately fluid resuscitated. In those that may not be intubated, you can also perform a bedside echocardiography. And under those circumstances, what you can do is you can measure what their left ventricular outflow tract VTI, which is a marker of the patient's stroke volume is. And VTI stands for velocity time integral. You can check what the stroke volume is on these patients under echocardiography with passive leg raise. You just raise their legs for 5 to 10 minutes and see what the difference in their VTI is between before and after the passive leg raise. And if that difference is less than 15%, then you know that these patients are not fluid responsive. The reason why we do this is because it is believed that on an average, a patient holds about 2 to 3 liters of fluid in their legs. So when we raise the legs and force the fluid back into circulation against gravity, if you see that their stroke volume increases in response to that, then that shows that this person may be somebody who is still fluid responsive and may benefit from further fluids. That brings us to the next question, that once we have identified somebody who we think will benefit from more fluids, how do we decide between the choice of fluid? Should we give them crystalloids such as normal saline or lactated ringers, or should we give them colloids such as albumin or blood? One of the things that I always look at in post-surgery patients is that if their hemoglobin is less than 8, you should always give them some blood, which serves not just to improve their oxygen carrying capacity, but also helps as a choice of fluid that can help bring up their CVP. And in those that also have a low oncotic pressure, somebody who may be malnourished, whose prealbumin may be low, whose albumin may be low, giving them albumin may help, because these are the patients that are at the highest risk of their volume that you give going away from the intravascular into the third space and them not reaping the benefits of fluid responsiveness. So in these patients, when you resuscitate them, giving them any form of colloid is beneficial over giving them some crystalloid fluid. It is very important to remember that in addition to giving them fluid to fill up the tank that is, in this case, the heart, you also want to correct any electrolyte abnormalities that they may have. Any cardiac surgery is a massive fluid shift event that is happening to these patients, and it is likely that they may have a lot of electrolyte derangements. The three most important electrolytes to look at and correct for are potassium, magnesium, and calcium. It is also important to remember that none of the vasopressor medications work very well once your pH drops below 7.2. The most acidotic resistant vasopressor is the vasopressin medication, but even that is not as effective once you become very acidotic. So it is important to correct the acidosis in these patients. A good way to think about this is that in those patients where you have a mean arterial pressure less than 70, first ask yourself the question, is the tank that is the heart filled with fluid? And the way you measure that is through a CVP. If the CVP is less than 10, decide whether you're going to give them crystalloids or colloids, but either way, give them fluids to bring that CVP up. In those patients where you know that the CVP is greater than 10 and that the tank is full and you do not need more volume, in those patients, we must proceed to utilization of vasopressors. There are several vasopressors that are available. The first-line vasopressors under almost all circumstances is norepinephrine. And the way I initiate this medication in those patients that do not have adequate blood pressure is that I initiate it at 3 micrograms per minute, and then I increase it by 1 to 2 every few minutes until I reach a maximum dose of 20 micrograms per minute, or when I have achieved the adequate targeted blood pressure, in our case, that of a MAP of at least 70 millimeters of mercury. Another medication that can be used and is often used in conjunction with norepinephrine is vasopressin. This is a medication that I always initiate at 0.04 units per minute, and this is also the max dose. There are two schools of thoughts when it comes to utilization of vasopressin. Some folks say that we should start it and then up titrate it. I think of vasopressin as either an on or an off medication, where either you give it to augment the effect of norepinephrine, it makes norepinephrine more effective, or you just titrate it off. I generally do not titrate it. I either turn it on or turn it off. And when I do turn it on, I turn it on at the maximum dose of 0.04 units per minute. Another medication that is often used, which works on the alpha receptors, as we heard about on the previous talk, is phenylephrine. This medication I generally initiate at 20 micrograms per minute, and I increase it by 5 micrograms per minute every few minutes as needed to a maximum dose of 200 micrograms per minute, or until I achieve the targeted goal of a MAP of greater than 70 millimeters of mercury. Once again, it is important that as you're using these vasoactive medications, you always look for other things that may be causing hypotension and maybe making these medications less effective. And you always want to correct for those. So you always want to correct for acidosis. You always want to correct for hypocalcemia. Always check a calcium level on these patients. And if it is low, replete it, because a lot of these medications will not be effective if the patient is severely hypocalcemic. The other important concept to remember is that even in patients that may not have adrenal insufficiency, when you are in a shock state, this is a very stressful circumstance for the body. And even those that have normal adrenal function at baseline may go into what we call relative adrenal insufficiency when they're in the shock state. And in those patients, you have to replace the steroids by giving them hydrocortisone, about 50 milligrams IV every 6 hours, to supplement this extra need of the steroids that the adrenal glands are not able to make under these stressful circumstances. When all of the above therapies fail, there are a couple of last-ditch efforts that you can make to salvage the situation. One such medication is methylene blue. It is a medication that helps with vasoplegia because it binds to nitric oxide and causes the blood vessels to constrict. It is not something that you titrate. It is something that you give as a one-time dose. Generally, you give 1.5 milligrams per kilogram that is infused over 30 minutes. And if that doesn't work, you can give patients cyanokit or vitamin B12, and that is also given as 5 grams IV, and it's given as a one-time dose. These are, again, last-ditch efforts that you can try and see if a one-time dose will help make things better. What if all of these medications fail? Under those circumstances, if all the medications have failed and you are still not able to maintain a cardiac index of greater than 2.2 or a mean arterial pressure greater than 70 millimeters of mercury, then you have to rely on mechanical circulatory support. These are artificial pumps that will restore circulation through the body. And this is a busy slide that has a lot of different parameters that go into what pump you use and when you use it. But conceptually, the take-home message that I want you guys to take from this is that first and foremost, you need to identify, is this patient in refractory shock because their right ventricle is failing, because their left ventricle is failing, or is it a patient in whom both the ventricles are failing? Because the choice of temporary MCS, that temporary mechanical circulatory support that you choose, may depend on which of the two or both ventricles that you need to support. Each institution is going to have a different algorithm. This is just what I use here at our institution. And which of the devices you use also depends on what is available. But it is just something to know conceptually that when all the medications fail and you just need to support the body until it can heal from the stressful situation of the cardiac surgery, that you do have certain temporary mechanical circulatory support devices available to you to help out with that. So in conclusion, some of the take-home points that I want you to reflect on as you walk away from this talk is that first and foremost, we must achieve euvolemia in these patients that are in shock state after their cardiac surgery. You want to normalize their electrolytes. You want to take care of everything that is reversible that may be driving this shock state. You want to correct the acidosis. Remember that acidosis in itself can cause shock. Acidosis in itself can cause pulseless electrical activity. Acidosis in itself can cause you to be hypotensive. And when you are severely acidotic, none of the medications that you use to treat these states are as effective. Various vasoplegia therapies exist, as we talked about earlier in this talk and even the previous talk. And the goal is always to match the patient to the best therapy that is available for that patient. And when all else fails, when it comes to medical therapy, you can always escalate to temporary forms of mechanical circulatory support if the patient is refractory to these medications. But the key point up there is that all of these forms of temporary mechanical circulatory support are indeed temporary, and you have to have some kind of an exit strategy before you initiate them. With that, I will conclude my thought and my talk, and I appreciate your attention, and I will be happy to take any questions.